On this time, since our last presenter is in, she's going to take us through integrating psychological inclusion in fetal medicine, enhancing patient outcome and experiences. Please help me to welcome MsT MEKI. Like I've said earlier, she's not feeling well, so please, at the end of the presentation, do not bombard you with so many questions. Huh?
A very good morning to you all. Let me see if I can. Okay. I just wanted to make sure that I know how to maneuver through this. Once again, a very good morning to you all. My name is MEKI. I am a psychologist, and we are based at Padring Hospital, Bianehanda to be specific. And we are a group, I'm representing a group of psychologists and midwife counselors. We work with the fetal medicine unit at Padring Hospital. My presentation, as you can see, is integrating psychological inclusion in fetal medicine, enhancing patient outcomes and experiences in resource-limited settings. The critical need. I think I'm going to be answering questions that were asked before as I make the presentations. I think from the back there was someone who asked, why not train nurses in mental health so that they can be the ones to help the patient? What we are doing, I think, as Tino said earlier, we are empowering every single practitioner, be it from the nurse aide, from the cleaner, right up to the gynecologist or the obstetrician or the fetal medicine specialist or the sonographer, to be able to practice psychological first aid that is relevant to the patient, because our model is a patient-centered model, and it's a stepped care model that represents the patient's needs and meets the patient at their need. Yesterday's presentations were talking about outcomes and reducing mortality and meeting the baby and the mother right before the time that they need to be intervened with regards to endangering the baby. And in most, not all the presentations, there was no psychological safety that was mentioned. I think Mr. Zanga mentioned counseling, but that's as far as it went. So this counseling needs to be specific to the FMU unit, because I think, as we have learned, being a psychologist, being a mental health practitioner is not enough if you do not know what fetal medicine is, if you do not know the patient's need. So yes, it's important for us to empower the practitioner, but at the same time, you need specialized care that can meet the mother at her need. There is reduced counseling time, which impacts psychological safety. Cultural and religious biases influence decision-making, and lack of trust leads to non-compliance with medical advice. I think as practitioners, you will agree with me that a lot of times you advise mothers medically, but they will do otherwise because there is that gap of the cultural and religious element that is often missed. And again, we understand that as practitioners, your job is not to counsel the patient, so you do not have time given the amount of patients that you have to go through. So it's very important for us to include religious and cultural components when we meet the patient at their need. Otherwise, there is no medical adherence to what you would have advised the patient to do. The foundation of trust is based on 4 pillars, which are psychological safety, family involvement, patient trust, and open communication. We've spoken about psychological safety already, and it's very important to understand that going for a scan is marred by a lot of myths, a lot of speculations, and a lot of stigma. Because as much as you may think that it's as simple as going in and getting results or getting a diagnosis for your child, mothers are all not at that same level. A lot of them are told or believe amongst themselves, and this is something we have discovered when we do group sessions, that mothers will say, I do not want to go for a scan because if I go for a scan, my baby will die, or I will be told there's something wrong with the baby. So you are doing your work, but the mother does not understand the importance of your work. And also, if it's being done in a group setting where a mother feels like she is being singled out as if there is something wrong or she's an example of how not to carry a baby, the mothers will not comply to your medical advice. It's very important for us to have open communication. A lot of times we use these big words, rightfully so, because a diagnosis is a diagnosis, right? But unfortunately, who are you talking to? What level of education does that person have? Can you zone in and come down to their level so that the communication becomes honest and open and becomes palatable to the mother with whom you're trying to communicate and make aware of the possible dangers that the baby is in or even that the mother is in? So yes, amongst ourselves as colleagues, it's very important to use the right terms. But what about the mother? Does she understand? A lot of times we say that these women come from deprived financial backgrounds. But the honest truth is, every mother who knows or suspects that there's something wrong with their baby will find airtime or data to Google that condition that you have given them off the internet, and that poses a lot of danger. So when you come in as a practitioner and you tell them, they already have what they've been told by Dr. Google, who seemingly is more reliable than you as a trained professional. Family involvement is also very important. You come up with a decision for a TOP, for example, and you lay down the importance of adherence to the mother. But when she goes home, she has a family of consultants to consult. And that mother is going to go with what the family says, her partner or the close relatives or the one who is paying the bills. And sometimes religious and cultural professionals are more listened to than you as a medical professional. And building patient confidence through cultural sensitive care and understanding is also important to build the patient's trust. So what we have been doing is going through a pre-scan counseling, during care counseling, and post-procedure support. So at Padrinyato Hospital, what we have realized is a lot of these women will be sitting at the bench. And as Tino mentioned earlier, sometimes our clinic happens on a Thursday, and sometimes the mothers have to wait that long until they see a practitioner. But what will be going on in their minds? Some mothers will discharge themselves against medical advice. Some mothers will be taking in other things, for lack of a better term, muteuro, while they're waiting to go in for a proper scan. When this is happening, by the time you go in, you take them in for a scan, they're not going to listen to you because all the other practitioners have been there for them, have supported them. And this is merely what these mothers want. They just want to be heard, to be understood, and also to have whatever it is that is going on with them explained to them. So it's very important to go through pre-scan counseling. And despite having the long waiting periods, these mothers will sit outside a bench. We'll see one mother going in and coming out. And sometimes they come out crying. What is going through the mind of a mother who is sitting by the bench waiting to go in, considering that if you go in for a scan, you are bound to get a negative result, because these are the conversations that the mothers are having. So we go through the thorough procedure explanation, we discuss potential outcomes, and we include partners and families. And this is also in collaboration with the fetal medicine unit, because we do not work in isolation. And as we have learned over the months that we've been doing the fetal medicine clinic, we are merely psychologists, but it's very important for us to understand and learn more about fetal medicine, because there is nothing as harmful as talking to a mother who knows more than the practitioner. And need we add that counseling is not always accepted by everyone, because there are also a lot of myths. When you say to someone, "Can I talk to you?" oftentimes they feel they've been labeled or they've been singled out. So we have found a way that is culturally appropriate for mothers to agree to counseling even before they go in for a scan. And during care, we address immediate concerns, provide clear information, and respect their cultural beliefs. And then we have post-procedure support. We process emotional impacts, schedule follow-up sessions, and support grief and healing. You might ask, why grief and healing? Not all times do mothers go in and get dismal reports from the ultrasound scan or the antenatal scan, sorry. But there is grief that comes with being given a diagnosis or being given an outcome from your scan. And that is the grief that we tackle. We do not wait for a TOP. We do not wait for the outcome that is inevitable. We meet the mother at her need, which is after she has been told what is likely, what is the possible outcome to come out from the scan. We start her through the process of grief, because there's that element of loss. When a mother carries a baby, no mother ever expects that there's going to be a negative outcome. All mothers expect a positive outcome. So that grief comes with the diagnosis or being told what the likely outcome is. Okay, so the challenges in low and middle income countries. And unfortunately, you can't see the bottom part of the bar graph. But what we have seen is that in most low and middle income countries, the challenges that we meet is adherence to medical advice, which is reduced. And then we also have cultural and religious beliefs. We also have financial, lack of financial support or financial income. And then we also have lack of partner and family support, because we don't want to assume that behind every pregnancy, there is a partner. Behind every pregnancy, there is a supportive partner. The partner may be there, but we have present absent partners. And that is what we have seen in most of the cases with our mothers. And some of the challenges that we have also seen is the failure to understand what the diagnosis or the outcome is. Our impact at Parinyato Hospital is supporting the fetal medicine unit, creating safe patient spaces, enhancing clarity on conditions, fostering patient agency. And we start our comprehensive care model from the antenatal clinic, where we do maternal mental health education every single morning at the ANC. And this has helped mothers, it creates rapport between the practitioner and the mother, so that when you come in with an intervention that is psychological or mental health related, there is that memory of having seen you before, and it reduces the labeling and the stigma. Our patient experience transformation. Before we started, we carried out a survey, and we were looking at whether or not our impact is real, is necessary, and is actually needed. Because sometimes if you don't know, you may be imposing yourself on patients and they really don't want you to be a part of the model. So before inclusion, we realized that from the study, there was increased anxiety, there were misunderstandings between the practitioner and the patient, and also filtering into the families. There was non-compliance, and also there were cultural conflicts, and these also tally into religious conflicts. And after the inclusion of the psychological support, there are validated feelings, there's clear understanding, and better adherence and cultural sensitivity. The measurable impact, as you can see, there's 73% patient satisfaction, improved with psychological inclusion, 68% treatment adherence, better compliance with medical advice. There is 45% anxiety reduction, which has led to decreased patient stress levels, 82% family engagement, increased partner and family involvement. And this is an observation that we also make when these mothers are in the antenatal ward. There is a lot of anxiety, and a lot of them do not like it when the midwives come to them, because the midwives are delaying them. There are that delay between them and getting the scan and getting the results. So what we have done is we have helped these mothers understand that we're not enemies, and whatever it is you're going through, we're in this together. What we want is the best outcomes and respective care for your baby and for you as the mother. Our implementation framework includes training healthcare providers. We have trained 38 maternity staff. These are midwives, matrons included there as well, where we want to develop an empathetic communication skills and cultural competency strategy. Because if a mother goes through to a psychologist or a counselor and gets feels psychologically safe, but then goes back to the sonographer or the fetal medicine specialist or to a midwife and feels they're being violated, it then disrupts the whole process. So this is why you will find that the members of staff that we have trained to date were not a specific niche, but it was everyone who meets the patient at their every need throughout the maternity hospital. We are creating safe spaces. We have established environments conducive to open dialogue and trust building. Because of our religious and cultural backgrounds, often group/individual sessions are not encouraged, because if you pick someone out within a group, they feel labeled and they feel stigmatized, because amongst themselves, they then discuss possible outcomes as mothers, which are in most cases are not correct and not factual. And a family-centered approach where we ask a patient who they are with, whether the partner is present or not, whether who's coming to see them during visiting hours, and then we talk to that person as well, because these are the people that are bringing in prescriptions from outside and supposedly trying to mitigate the current condition that the mother is in. Continuous support, we do ward rounds every morning to those that are inpatient, And even to those that are outpatients that walk in, we have spoken to the sister in charge from the FMU, and we have said to her, we don't only want to wait for Thursday when there's a clinic, we would want to ensure that every time we see a mother sitting on the bench, we interface with her and calm her down until she gets seen. And then quality monitoring, we assess outcomes and refine practices based on patient feedback. We also do follow-ups for these mothers. After 6 weeks post-discharge, we then call or send a text on WhatsApp, and we find out how they are doing. Lastly, we have 2 cases that we would want to refer to where real impact happened. There was informed acceptance in case 1, where there was a 35-year-old woman, P4G5. She was from Bindura, and she was facing this complex diagnosis because she didn't understand what it was. And our involvement in the fetal medicine unit has enabled us to have a deeper understanding of what the diagnosis is. And we're privileged that Dr. Verenga, Sister Julie, and their team have allowed us to sit in as the scan is taking place, so that as the mother understands or gets a better understanding of what is going on with her baby or what is going on inside of her, we are able to then check her nonverbal cues as she's getting the explanation, and then take her following that diagnosis and walk her through her journey until delivery, regardless of a positive or negative birthing outcome. This woman had diaphragmatic hernia, and she had Schmidt syndrome. And these are terms that, as a psychologist, I never thought I would need to learn. But here we are. So this is why it's important to have a specialized psychological care that is dedicated to the fetal medicine unit, that understands the diagnosis, what it means, what the possible outcomes are. And I think yesterday there was a question again from the back where they asked, I think it was Dr. Hlatshwayo who was asked, what do we tell a patient when you get given a diagnosis and the mother wants to know what the outcome is? In psychology and in ethics, we always do no harm, and there's the issue of non-malfeasance. So it's important for us to be very open and honest with the mother so that we do not increase her expectations. But often with medical practitioners, there is a level of factualism that is quite denting to the mother. She feels there's no empathy in it. And we understand there's no empathy in a diagnosis. It is what it is. But we believe you can always tell a patient to go to hell and make sure they look forward to it. The mother was receptive to comprehensive pre-scan counseling and appreciating the clear, empathetic guidance. And she agreed to TOP, and she also demonstrated how the psychological safety and inclusion helped her understand what the whole team were trying to do for her. In case 2, it was an issue of processing grief and anger. She did not want counseling. She did not want to talk to anyone. She said, the doctor has already told me the outcome. Nothing is going to change. The team went to her 3 times and she refused. On the 4th time, I went in, and again, it's always about how you interface the patient. We started a basic conversation, which led to a therapeutic intervention. So this is why we're saying, yes, it's important for practitioners to be trained, but it is then important for us to work together to provide a comprehensive and holistic package that benefits the patient and increases better outcomes. This patient was a 25-year-old P1G2. She lives in Harare, and she had skeletal dysplasia and bilateral choroid plexus cysts. And she said, but I have seen a lot of other children or people who have skeletal dysplasia and they are alive. But this is because after she had seen the doctor and the nurses, she went and she Googled. And after Googling, she went against what she had been told by the team. Only when we sat her down, we met her at her need. What did she understand from the diagnosis? What did she find out? What did she know? Because we made her the specialist. So she told us what we knew. And then we came in with the information that we had received, the medical information, the factual information that we'd received from Dr. Verenga and from the FMU team. So it's very important to have that team that can sit the patient down, because often at times, given the amazing work that everyone in this room does, especially in public hospitals, you find a lot of times you are labeled as people who are inconsiderate and people who do not want to put patient care at the center of your interventions. So only after this fourth attempt did she then break down, cry, start processing her grief, and we realized that she was angry. She was angry at herself. And we also then realized that there was a psychosocial background to her situation and her failure to accept. She was having marital issues and she needed that baby to stay married. So it wasn't because of what Dr. Verenga and the FMU team had come up with. It was because of her social background, which is why she became a problem for everyone in the ward. In conclusion, psychological inclusion in fetal medicine is not merely an enhancement, it is a necessity. And together we can transform fetal medicine to ensure every patient feels heard, respected, and cared for. We hope we are not stepping on anyone's toes. We are not there to take anyone's role. We're there to enhance and make sure that our patients are given the best care, respective care, and whatever interventions that we come up with, whatever the diagnosis and the outcome is patient-centered and the best for the patient. Thank you.